So tonight is our McLean and Me educational series, and the topic is navigating insurance and Medicare. My name is Kate Holmes. I'm a senior living specialist at McLean, and I'm your moderator for this evening. I am not an expert in this topic at all. That's why we have a panel to the left of me. But I am a consumer, because last year we decided that it was better for my husband to go on Medicare, and I kicked him off my insurance. And so I took out that book that they send in the mail, and I started reading it, and I went, oh, I can't, this is ridiculous. So my sister-in-law nicely directed me to our panelist to the far right, or far left, my far left, John Patera. And John is a principal partner, see if I get this right, principal partner, a licensed agent with Senior Health and Retirement Services. Are you Madison, New Haven?
Yeah.
In Madison.
Madison and Colchester.
Yeah, and John was so patient in answering. I asked a lot of questions. I'm a researcher, and he answered my calls and my emails, and he was just great. And then I presented all of this information to my husband with my recommendation on what he should choose, supplement, traditional with a supplement, or advantage, the whole thing. And he promptly chose the opposite of what I did, what I recommended. But he made a fully informed decision because I did all the research. And that is why I am moderating tonight. John is going to give a presentation and highlighting some changes that are happening this year, 2025, in Medicare, and that will start in a moment. And I also want to introduce our second panelist, who is McLean's very own, Michaela Viglione. Michaela is our Director of Admissions. I know some of you here have worked with her. She is Director of Admissions not only for long-term skilled nursing, but also for inpatient post-acute. So she's got a whole different perspective about insurance, and she also can answer questions that are specific to McLean. So we have a lot of residents in here, and you might have, as you're getting notices in the mail about what's happening, Michaela can address all of those. All right, also a little housekeeping. If you want to hold your questions till the end, John says he doesn't mind if you interrupt him, but if you want to hold that, there's pad and pen at your table so that you can jot them down. And there's also some surveys there. Because we do this series, it's an educational series, it's for our residents, as I said, in the community. And if there's some topics that you're really interested in, we'd love to make that presentation. So if you fill out the survey, we really appreciate it. Okay, so without any more fuss from me, I'm gonna hand the mic over to John.
Thank you. Thank you very much, Kate, and thank you for your kind words. So I'll just give you a little more background on our agency, but the one thing I wanted to highlight, since it's on my mind, this relates directly to what Kate was saying, is Medicare and insurance really is about making an informed decision. I'll tell you right up front, there's no such thing as a right or wrong answer. There's no such thing as the best insurance. It's a personal decision based on what you're comfortable with, based on how you want to pay for your health care, based on what kind of coverage, and definitely based on maybe what's going on with your health at that present time. So, if anyone ever says to you, friends, family, hey, I got the best, this is what you need to do, I would advise against listening to that kind of advice, because everyone in this room, including husband and wife, are an individual, and everyone gets to make an individual decision, and everyone's right. This is the one situation, maybe the one, that I can actually make the comment, everyone's right with that. So. Kind of a quick opening, and then again, so I'm here from Senior Health and Retirement Services. Our agency's been around for a little more than 20 years. Again, Madison, Colchester, we have 2 offices. My wife, Kristen, in the back, did start that agency originally, and then I joined at a later date, but we have 20 agents that work for us, and the most important thing I can say is, we were just talking about this, we're a full service agency. So one thing, we do a lot of these community type events, educational events like this, because we want to give back and we want to educate people, but we also kind of take that mindset into what we do in our business, which is we're not just here to enroll people, We're available 24/7, 365 days. This is obviously a busy time for us, but we're there year-round to service any of our clients and answer any questions. So, and again, either way, I know we want to wait to the end with questions after I go through some things, but I don't mind. So up to you guys, not to break the rules.
I just want to, can everybody hear John?
Yeah, is it good?
It needs to be closer
A
to.
little closer? Is that better?
Okay.
Oh, that sounds like a ball.
All right, sorry, John, I interrupted you. No.
No, I like it. I actually like being interrupted. So the presentation I'm going to go over tonight is extremely high level, okay? Short presentation meant to kind of answering kind of the pressing questions, focusing around what's changing, specifically around what's changing on prescription D drug coverage for next year. So to just get right into it, oh, this works. So I did want to just throw out the couple changes in premiums that affects everyone. So these are the increases in Medicare for 2025. Your Medicare Part B premium, and this is standard, so there are some adjustments that can be made, but for most of us, we pay the standard Part B premium, which is going up $10.20 for a total of $185. That comes out of your Social Security check. The Part B deductible, for those of you that have Plan G, this is what you're responsible for. This year it was $240, up $17 to $257. The last one I'll put out there, and this would really only apply if you had just original Medicare, is the Part A deductible is up to $1,684, which is an increase of $52. So again, I think the big one that'll impact most people in this room is the first one. And you know, things go up every year, there's your increase in Medicare, about $10, okay? So, getting right into it, the big change, you hear big changes right in Medicare. So what the big change is directly related to the Inflation Reduction Act of 2022. So the Inflation Reduction Act was passed with impact on Part D prescription drug coverage, and these impacts were phased in. So first I'll just highlight the things that were already in effect. So the first thing that went into effect is insulin for anyone on Medicare prescription is capped at $35 a month, okay? That's already in effect. So for those, if anyone in this room is on insulin, you're probably aware of that, and that's a really good thing because insulin is expensive. So $35 max, already in place. Second thing I'll note is that this year, all vaccinations, immunizations, anything like that went to zero. The one that was usually missing prior to this was shingles. So if anyone got the shingles vaccination this year, you probably noticed you didn't pay for it, okay? Which is a good thing. The other thing I'll highlight is, as you'll see some years being phased in, but the other thing the Inflation Reduction Act did is it gave the federal government the ability to negotiate directly with pharmaceutical companies on the cost of those drugs for Medicare participants. So that has already happened. They did pick the 10 drugs that were negotiated. We saw a nice decrease, but I'm not going to get a lot into that right now because it doesn't go into effect for you guys until 2026. So even though you may hear, oh, you know, Eliquis is negotiated to this price by the government, doesn't matter until 2026. So the big one for 2025 that has all this upheaval and commotion out there is, first and foremost, the donut hole coverage gap has been eliminated. So for those of you that go into the coverage gap or donut hole for your prescription drugs, you know what this is. It's when your prescriptions all of a sudden mid-year start becoming more expensive. And that's because you were charged 25% of them. That is eliminated. And the reason that has been eliminated is because there is now a $2,000 cap on all prescription drugs. Now that $2,000 cap isn't just as simple as, oh, once I pay $2,000, I'm done. There's some calculations and there's what I'll call some credits that the insurance company you choose give you that go towards the $2,000. Before we get into how it's actually working next year, what I'll tell you is also, if you have a supplement with a Part D plan separately, the monthly premium on that prescription drug plan does not count towards the $2,000. The $2,000 max is comprised of your deductible and your copays. Okay? So, I'm going to explain how drug coverage is working in 2025. So there's 3 stages, there used to be 4. You see in red, I already mentioned it, I'll just mention it again. In red, you have the donut hole being eliminated. So now 4 stages in drug coverage are down to 3. The first stage is your deductible. Medicare comes out with a maximum deductible every year that they allow. Next year, that maximum allowable deductible is $590. So, that $590 maximum deductible is going to be credited towards your $2,000 max, whether your insurance company charges it to you or not. So if you happen to be in an insurance plan that's saying, we're not going to charge the deductible, right? It's up to them. They can charge it, they don't have to. And there's many policies this year that are not charging the $590 deductible. Some are charging a portion of it. But you are credited with the full $590 regardless if you pay it or not towards your $2,000 max. Okay, so that's a good thing. So $2,000 really equals less than $2,000, which is cool. So the next stage of drug coverage after you pay the deductible or you don't pay the deductible is called the initial coverage stage. This is when you typically pay copays or coinsurance at the pharmacy. So the maximum allowable credit that you can receive for the drug, as you see on the slide, is 25% of the drug. So here's the deal. An insurance company can say, we're charging you 25% of the drug cost, and then it's kind of even money, right? You paid 25%, and 25% was credited towards your $2,000 max. But if a company decides to charge you less than 25%, or maybe even a fixed dollar amount, you're still credited with the 25% of that drug. So that is applied in the form of what I'll call credits. So once your credits and your money that actually came out of your pocket reach $2,000 for the year, you are done paying for the year. That is referred to as the catastrophic stage, which is stage 3. Okay? So many plans you'll see, and we can calculate this through the tools we have, you may only pay $1,100, but you hit that $2,000 max. You can even pay less than $1,100 with some insurance companies to hit the $2,000 max. Again, once that happens, you're done paying for the year. One other thing I want to mention, it's just kind of at the bottom of the slide here, is that if you choose, because what's going to happen is insurance costs for prescriptions are going to become very front-loaded, right? You're going to pay a lot at the beginning of the year, and then at some point you potentially will pay nothing. If you don't like doing things that way, and you prefer to go on a payment plan, your insurance company has the ability to calculate your drug costs for the year, divide it by 12, charge you a monthly bill. You'll get a bill in the mail in the form of a statement, and you pay 0 at the pharmacy. You just pay your monthly bill. The pharmacist will know when you go fill your drugs, oh, they're on a payment plan, they're paying monthly, here's your drugs, you owe me nothing. So think about that. Regardless what type of insurance you have, as far as your Part D coverage, if you prefer to pay monthly and spread those costs out over 12 months, that is initiated through your insurance company. They'll set it up for you. Okay? So, move on. Again, we're high level, and I look forward and welcome questions at the end. It's a little weird because I take questions as I go along, so I always typically say, any questions, anyone? But I'm not saying that. I didn't say that. So what I'm going to just want to go over quickly is what original Medicare is and what it does not cover. So original Medicare, as you see here, is comprised of Part A, Part B. As you see, Part A is hospital coverage, Part B is medical coverage. There's 3 gaps in Medicare. There's deductibles, coinsurance, and prescription drug gaps. Specifically, the deductibles you saw on the last slide. That's money that would need to be paid prior to the original Medicare kicking in. The co-insurance is specifically on Part B. Part B only covers 80% of medical. You are responsible for 20%, and that 20% has no cap on it. So simple math, if you had a medical bill that was $100,000, guess what? You owe $20,000. In original Medicare, there is no prescription drug coverage. So those three gaps are pretty substantial, and I don't recommend anybody ever just have original Medicare. It's not advisable. It's too much risk and no drug coverage. So there's two options and ways you can fill those gaps. The first option under option 1, which I'm sure many people in this room have one or the other, is a Medicare supplement. Medicare supplement is a secondary medical coverage which leaves original Medicare as your primary insurance company. Original Medicare is still making all decisions, pre-approvals, paying their claims, etc. The private insurance company is a secondary that would come in and pick up potentially all of the costs Medicare doesn't cover. Again, there's some varying different supplement options, but they're going to cover most of what Medicare does not cover medically. With that type of coverage, you would need a third insurance policy. So third, original Medicare is still in play. Your secondary medical is a supplement through a private insurance company. You would then need to pick up and choose a prescription drug plan, which is a totally separate policy. So that's option 1. A couple notes. Option 1, since original Medicare is still your primary coverage, there are no networks like private insurance companies have. You still have to go to a facility and a doctor that accepts Medicare, which seems to be dwindling. So it's not carte blanche, it's not go anywhere you want. They still have to accept original Medicare, but we will say no networks nationwide for this coverage. Also, no additional coverage. So on the downside of feature is that secondary insurance can only cover what Medicare covers. So if Medicare doesn't cover things such as dental, vision, hearing, they're the ones you always hear about, they would not be included in option 1. You certainly could purchase those things. Going on to option 2. Option 2 is a Medicare Advantage plan, sometimes referred to as Medicare Part C. Most of them do include prescription drug coverage. You would only not include prescription drug coverage in your Advantage plan if you elected to because you had drug coverage through, say, the military. You have VA, you have TRICARE. You can select a Medicare Advantage plan that does not cover drug coverage and still get it through the military. But in most civilian situations, I'll call it, your Medicare Advantage plans is going to have prescription drug coverage. So these are offered through private insurance companies. And I'll quickly explain kind of high level what a Medicare Advantage plan is. It's basically the federal government subcontracting out to a private insurance company to take care of 100% of your health care and become your primary insurance company. That means that private insurance company is now making decisions, fulfilling claims, administrative costs, whatever comes with your health care, that private insurance company of your choice, I stress that, of your choice, you're not going to be forced to take one thing or the other. There's a lot of really good options. But in return, the federal government is going to pay that private insurance company between $8,000 and $12,000 a year on your behalf. Where did the government get that money from you? You pay taxes, payroll taxes specifically for your whole working life or your spouse's working life. So you're really just kind of recollecting on something you've already paid for. But these private insurance companies are being paid out of the Medicare budget, which means typically, and in most cases, the monthly premium is zero. There would be a monthly premium on option 1. There are co-pays associated with, which are very important. You have to understand what your costs are for that particular type of insurance. It's nice to say I pay 0 per month, right? Everyone wants to say I get to pay 0, but you gotta understand what the costs are when you use non-preventative medicine. Preventative medicine is still at no cost. So a couple other features of this option. One, there are networks. So just like if you remember back to your employer plan, there was a network. There are a couple companies we have access to in Connecticut that have national networks, which means cross the boundaries of Connecticut has no impact on your coverage. You still have to stay in network though, but state boundaries don't matter. So very, very important, I stress this is how people get in trouble with Medicare Advantage. You need to check your doctors. Or more appropriately, have someone such as myself or an insurance agent that's licensed with Medicare, check your doctors and make sure they participate. See, too many people just wing it and take the plan that their brother-in-law had, and all of a sudden their doctor doesn't participate, and they're like, uh-oh, gotta check your doctors. Also, this particular type of insurance would come with extra things. You see them all advertised on TV. A lot of commercials out there, right? So dental, vision, hearing, over-the-counter, rides, a lot of nice, valuable benefits that come with this type of insurance. The insurance companies under option 2 have to cover everything that original Medicare covers. So sometimes there's some misinformation out there around Medicare Advantage that it's less or inferior coverage than Medicare. It's impossible. A Medicare Advantage plan must start covering everything that Medicare covers. They then will add on additional coverages, the dental, the vision, hearing as well, okay? So those are the decisions that really you have to make. And this is why I said at the beginning, I'm glad I said it at the beginning, this is an individual decision. It's a lot to take in, and this is, again, high level, kind of quick overview tonight. It's important you make a thoughtful decision. These are very different options. Just make sure, and again, we certainly provide that service, as a lot of other Medicare agents do. So it's important to get a good trusted advisor. So next thing I have here, I just want to highlight the enrollment periods. These are important. So first and foremost, we have what we're in right now. This is the annual enrollment period. The significance of this, first you see the dates, October 15th to December 7th. Any change can be made. And this period of time is not only important because any change can be made, it's also important because this is when Medicare Advantage plans and drug plans can change. You will get an annual notice of change about the changes in your plan. It's important to understand what's changing. There's plans out there that had a lot of dental last year that have no dental this year. I want to see anyone wind up going to the dentist and in their insurance card to be told you're not covered. It's important to understand the changes, okay? That comes again in the form of an annual notice of change. So this period is significant because you can say, wow, I don't like these changes. I'm gonna look for something else. Or you can say, hey man, this plan's getting better, or I don't mind the changes that are being made. I'm sticking with it. So the second enrollment period I highlighted up here is called the open enrollment period. So the important thing to know about this enrollment period, again, just to highlight the time frame, January 1st to March 31st. You must have a Medicare Advantage plan already to participate in this enrollment period. So this is when you can change Medicare Advantage plans. You get a second crack at doing that. This is when you can also go back to original Medicare. Let's say for whatever reason, maybe it's health, maybe it's comfort, whatever the reason, during either one of these time periods, you can leave a Medicare Advantage plan and go back to that option 1 on the previous slide, which is original Medicare, a supplement, and a drug plan. One thing I really want to point out about that specific change, very important to know this, because where we're sitting in Connecticut, okay? In case we check on that. So Connecticut is one of the 4 guaranteed issue states. What that means is if you wanted to join a Medicare supplement later in life, you cannot be underwritten for health, age, gender, smoking, nothing. Guaranteed issue. It means that they have to accept you for the exact same price they accept everyone else. So, we're very lucky in Connecticut, amongst other reasons. We're very lucky in Connecticut because this affords people the ability to quite honestly, get sick later in life and be on a Medicare Advantage plan, and during one of these periods of time saying, I'm switching my insurance, and it has no impact on my cost or acceptance. So I really try to stress this because that is not the case in 46 states. So if anyone plans on going to a different state, we need to have a different conversation. But Connecticut is guaranteed issued. So that's a very good thing. And then lastly, I did highlight a couple special enrollment periods. If you retire after 65, you're able to go on Medicare, no penalty. That's more misinformation. There is a form that needs to be filled out by your employer to say you had credible coverage during that period of time over 65. But you can absolutely, anytime you retire, you can transition to Medicare. Secondly, I have up here if you move. I mentioned if you move out of state. If you move out of state and you're on a Medicare Advantage plan or prescription drug plan, you have to change it. They have service areas. That insurance is only good in the service area you live in, which is where this whole check your zip code thing came from. J.J. Walker and William Shatner, I guess, or Joe Namath, whoever's on those commercials. But that's why the zip code matters, because if you move, you would have to change plans. And our agency is licensed in about 15 states, and we help many of our clients that decide to go to Florida or Vermont maintain their insurance throughout that move. Last one I put up there, if you qualify for assistance or Medicaid, you're afforded some special enrollment periods for that. There's a bunch of other ones, but those are the special enrollment periods that I wanted to highlight. So, and then, one second. Good thing I'm coming to the end here. Starting to get a little hoarse. I talk all day, but so last thing I just wanted to highlight, and this is kind of an interesting slide because it's both ends of the spectrum. So the first slide talked about the cost of Part B. Well, there is an income aspect to Medicare, and it's on the low end and on the high end. So on the low end, there's a program in Connecticut called the Medicare Savings Program, and I just highlighted here, there's a couple different levels to it, but I highlighted here the qualifications. $3,088 and below for a single individual, $4,191 for a married couple. Below that, you should be talking to someone such as myself, because potentially you have your Medicare Part B paid for, your prescription drugs capped, and your medical co-pays at no cost. Okay? Then lastly, and it's really good we're coming to the end. Probably should drink water instead of coffee. So on the high end, I highlighted that as well. There's something called IRMA. It stands for Income Related Medicare Adjustment Amount. So for any single individual on your adjusted gross income making over 103, you're going to pay more for your Medicare. Any married couple making more than 206 is going to pay more for their Medicare. And we'll go here. Almost done. So I bring this up, thank you very much. I bring this up because typically people think, oh, I'm retiring, my income might drop, and I'm probably going to go down and only have to pay the standard amount. One thing that catches people off guard that I want to highlight is required minimum distributions. So a lot of people in this room have IRAs. Guess what? At 72 and a half, you got to start taking that money. Why? Because the government wants their piece. They want the taxes on them. So a lot of people, kind of retire. They'll kind of see a lull in their income, and then all of a sudden they'll see spikes in their income. Or maybe you'll cash in an IRA. Maybe you'll come into an inheritance. Maybe you'll sell a property. These are all reasons that you could see your Medicare spike and be considerably up to over $600 a month. Now, when the government's looking to charge you for your Medicare, they're looking at 2 years in the rear. So right now, we're in 2024, they're looking at 2022 taxes. In a couple months, When we're in 2025, they're going to be looking at 2023 taxes. So there is an appeal process for a life change event. So if you see a decrease in your adjustable gross income year over year, you do not have to wait 2 years for that to catch up with your Medicare premiums. There is a process that you can appeal, provide your tax returns, and have your Medicare premiums reduced to what they should be, not based on what you earned 2 years ago. Okay? And thank you. That's me. That's where I am. So I don't know if we're going right to questions or we're going to do.
Yeah, I think so, right? I think if anybody has any, can you hear me? Because I'm loud. If anybody has any questions, and then you could direct them to John or to Michaela if you have questions specific to.
Yeah, we can.
You guys will trade.
Pass it back.
Can
Pass the
everybody
mic.
hear me okay?
Then eventually we'll drop the mic.
Yes. And then direct them, and we'll ask John or Michaela to repeat the question so everyone can hear it.
Absolutely.
Unless you don't have any questions. Who's got questions?
Yes.
I'll ask. I know you said that there's not a right answer for every person is individual. Can you tell us what you think is one of the things that people often overlook when they're making their decision?
So I think, so the question was, what do people overlook when making a decision on what option to choose for Medicare? You know, the easy is when you got to check your doctors and drugs. That's just like a canned answer a little bit. You can't enroll in a plan without someone or you checking if your doctors accept that insurance or if your drugs are covered by that insurance. You know, that question becomes very difficult on the flip side outside of that, because one thing I realize is we can't see the future. If anyone in here can see the future, talk to me after this. We're going to take a trip. Well, we can. I'm joking, but right? We can't see the future. So the whole decision in mind, you know, we highlighted a couple differences, but the decision comes out to be, how do you want to pay for your health care? And if you're healthy, we don't know if we're going to get sick. We don't know if we're going to get an unfortunate diagnosis, okay? So you got to make a decision that you're comfortable with, understanding. I will tell you, all Medicare Advantages have max out-of-pockets. So you do have a safety net that if you do get sick, your costs are going to be capped on a Medicare Advantage plan. And I'll kind of break down what those cost caps would be. So if you go with a Medicare supplement and drug plan, you're going to basically commit to about $3,500 a year if you use healthcare or not. That money's gone. But you have the knowledge of knowing you're not going to get any copays or doctor bills in most cases. So you might say, wow, $3,500 just in case is a deal. On the flip side, if you take a zero premium Medicare Advantage plan, the cap is going to range. Now, Medicare allows all the way up to like $8,900 cap. That's what's permitted. There's plans as low as $4,900. So there's Medicare Advantage companies that will offer a very low maximum out of pocket that make it more appealing for someone that's maybe a little worried, what if? So I think, did that answer the question?
Yes, thank
Okay,
you.
thank you.
Anybody else? Oh, yes.
In a past year's presentation, I remember seeing a chart with the different supplement plans listed, and then the premium for each one of those plans. Do you have one of those charts?
I do have that chart, actually. It comes out based on the state. Yeah, I can provide it. I'm sure there's a copier here somewhere. But the question was about the different Medicare supplements available and the prices. So I do want to add a little bit to that question. So Medicare supplements are standardized, which means they are the exact same thing regardless what company you buy it from. So the most popular supplement nowadays, and quite honestly, in my opinion, my humble opinion, the only one that makes sense is Plan G. G is in girl. So Plan G is identical regardless who you buy it from. So you have Plan Gs that range, quite honestly, from, I think the lowest right now is about $211, all the way up to probably $600 or $700. And they're identical. So that's a great question because these prices change annually. And it's important to have maybe an agent, Kate and I talked about this recently. It's important to have an agent that's looking out for this because if your company raises the price, you have the ability to make that change at any time during the year. Those enrollment periods don't matter. So if your supplement company says, we're increasing your payment by $50, and another supplement company is much less, you can switch that month, any month. There's no enrollment period to make that particular change. So yes, I do have that chart that you're asking for and absolutely can provide it.
So why do you say Plan G is?
Yeah, great question. So the question was, why do I, in my humble opinion, believe that Plan G is the option I would recommend when it comes to supplements? So let me take the comparison on Plan F first. So first off, know that Plan F has been discontinued, but if you turn 65 before January 1st of 2020, you can still get Plan F. But here's the difference. The only difference between Plan F and Plan G is the Part B deductible, and as we saw on the slide, that's $257. On average, Plan F will cost you about $1,300 more. So, is anyone in this room willing to pay $1,300 to get $257? No. That's why I don't like Plan F. On the downside, there's like an alphabet soup of supplements. And you have all these supplements, will cover 50% of this and 75% of this, or we'll charge you co-pays, or we'll charge you a large deductible. The way I look at it is, if you're choosing a supplement, it's because you want to be a fixed price and not see any co-pays. That's the main reason, not the only reason, but the main reason you choose a supplement. I want a fixed price and I don't want to see bills. So all those other supplements, the high deductible plans and the one Plan N with co-pays, to me, you're better off in a Medicare Advantage plan that's going to charge you $0 and you're going to have costs. But, I will say it again, no right or wrong answer. So if you have Plan N and you like it, or one of these other ones in the alphabet soup, and you like it and it's working for you, that's all that matters. But my preference is Plan G. So, thank you. Yes?
So, but the other reason for the supplemental is the network thing. If you, especially, it's like if you're moving to different states that you're living in.
Yeah, so I'll address that. And right, so are there doctors that take just supplements or just original Medicare and not Medicare? Yes, it's very rare, I'll be honest. You know, we're lucky because, I keep touting Connecticut here, maybe they should pay me an endorsement fee or something, but, we're very lucky in Connecticut. We have an incredible healthcare system in Connecticut, we really do. Not only that, we're in a population center with a high population. I run lists of doctors every day, literally every day. And it's rare that I can't find a Medicare Advantage plan that doesn't cover every single doctor you want. And again, there's national Medicare Advantage plans. We got snowbirds that live 6 months in Florida, 6 months up here. I can give you primary care doctor on a Medicare Advantage plan in Florida. I can give you a cardiologist in Florida, a dermatologist. I can do the same here. So you can do that with a Medicare Advantage plan. So it's just nowadays in 2024, the networks and the availability of and doctors accepting in this area on Medicare Advantage, quite honestly, the network thing is kind of far down on your list while you make a decision. Now, if we're living in the middle of Montana or Iowa, or wherever these places, that's a different conversation. Because the network's probably not built out on Medicare Advantage, where the supplement does matter for network, but we're very lucky in the Northeast in this population center. I don't find it to be an issue. Okay, so.
Thank you.
So you mentioned there are a couple of plans that covers the nationwide. What are those?
Yeah, so the question was, which Medicare Advantage plans are national? So specifically, it's United Healthcare and Aetna. Blue Cross and Blue Shield kind of does it, but if it's important to someone to have a national network, those two companies do a tremendous job on their network nationwide. Both of them, I think they're up to close to 1.5 million doctors nationwide that accept United Healthcare and Aetna Medicare Advantage plans. So you can absolutely, again, we'd have to check your doctors, but you can absolutely feel comfortable if you're a snowbird or need coverage in multiple states. I mean, we had a client recently, I'll give you an example of what you could do. This was a United National Plan. She was having a knee surgery. She lives by herself. Knee replacement, pretty standard procedure, right? They do them every day. They don't even keep you overnight anymore. But you do need rehab on a knee surgery. So her closest relative was her son in Philadelphia. So she actually, with her Medicare Advantage plan, had the knee surgery performed in Philadelphia so she could go stay with her son. A physical therapist from Pennsylvania came to his house, performed physical therapy. When she was feeling better, she came back to Connecticut, no questions asked, no impact on her cost. They were in network. So, yeah, that's relatively new too. You know, it used to be like those kind of things weren't possible. So, yes, and if you want any input, I talk a lot. So, yeah, either. Thank you. Yes.
Could you go over the IRMA increase again?
Yeah.
I had a situation where in 2022, I sold some rental property and the gain was considered income. And is that what would kick up the premium for 2 years?
So you probably saw an increase in your Medicare and go, what just happened? Like, why am I paying more for this? So here's what happened. So the question was specifically, explain the income-related Medicare adjustment amount, which is when you will pay more for Medicare. So the first and most important thing to know is what number the government is looking at. It's your adjusted gross income. So yes, if you sell a property, if you have capital gains because you sold some stock, if you cashed out an IRA, some of that money's coming over and is included in your adjusted gross income. So, and I do have the IRMA chart here. There's brackets. I think there's 6 brackets where you'll pay more money. If in fact you do have an increase due to one of those reasons, or as you did, you sold a property, come January 1st of 2 years, right? So this year, again, they were looking at 2022 taxes. So if you had that increase in 2022, your Medicare went up. If in 2023, that it's a one-off, right? It's a property sale. It's only going to show up one time. If when you do your 2023 taxes next year in 2025, because 2 years passed, they're going to know your adjusted gross income dropped, and they're going to lower your Medicare premiums accordingly. The appeal process would have allowed you in that specific scenario, as soon as you did those 2023 taxes, say in April of this year, and that income was no longer showing, you could file the appeal form, which we help with that, and they would lower your Medicare premiums retroactively back to the first of the year. So you don't have to wait 2 years. If you have a taxable event like that, as soon as you do taxes that don't show that income anymore, you have the ability to appeal your Medicare premiums, and should. So, yes?
I have a Medicare Advantage plan that I've used for 3-4 years, and they had all my physicians. For 2025, they cut them all out.
Oh, boy.
Is that occurring? You find that? And I'm weighing whether to just keep the plan and pay the higher co-pays, and am I expected to pay a larger percentage of co-insurance procedures?
Yeah, so I mentioned a couple, the question was about having a Medicare Advantage plan, letting it roll over from year to year, and then seeing some massive changes in the doctors that accept it and the payments, co-payments. So I mentioned a couple times that when you first join a Medicare Advantage plan, you should check those doctors. Well, I probably misspoke a little bit, and I want to expand on that and say every year you need to check that. And you've obviously probably found it out the hard way. They probably sent you a letter informing you that. I'll just say it, you should change. That's why we have this period of time right now. You should find a plan that all your doctors are in network, it's not that hard, and that all the co-pays are to your liking, the benefits are to your liking. There's like 40 some plans and options. You're a free agent right now. So if they do something you don't like, go somewhere else.
But any team you want.
You can go to any team you want. You're a free agent. Yes. Yes.
Hi, I was just wondering if Michaela could speak to
Yes.
what McLean accepts for and the differences between the Advantage plans and traditional benefits.
Yes.
So if you live in McLean, that is really the only time network is important, because unfortunately we do not take every insurance under the sun. So quickly, if you need to come to the health center for any reason, for rehab, obviously we do take traditional Medicare, we do take Connecticut, we take Aetna, we take Cigna, we take Blue Cross. We take select United Healthcare plans. Typically it is a PPO plan with out-of-network benefits, because we are out-of-network with United Healthcare. So that's important to keep in mind. In very select cases, if you do have an insurance we don't take and you do live here on campus, we will do a one-time contract with that insurance company to make sure we can provide you care here on campus. And again, as far as rehab goes here, which is when most people are using their insurance, Medicare, if you have a 3-night inpatient stay at the hospital, it's important to highlight inpatient. A lot of times they'll say, oh, we're admitting you, but it's actually to observation, not to inpatient, and unfortunately you will get tripped up, and if you do need rehab, it will not be covered, and it is entirely out of pocket, which is extremely expensive. So that's important to keep in mind with traditional Medicare. And then just for managed Medicare, you do have to get a prior authorization before you come to rehab, and that company, whether it's Aetna, United, Blue Cross, they are managing your care and dictating how long you can be in rehab. Amy?
Does home care accept the same insurances?
Home care does not always accept the same insurances as inpatient does, so that does get tricky. I know in one case, our home care, McLean Home Care, doesn't take Blue Cross.
Could you explain the caveat on the United Healthcare? Because you accept United?
So we are out of network with United. However, a lot of the Medicare Advantage plans through United are PPO plans. Most of those PPO plans do have out of network benefits. There's varying levels of copay. If you are Medicaid eligible, the dual PPO plan, you don't pay any copays with it. Some of them have a $250 copay, so it just depends on the plan. So yes, we can take United, but it's very specific. So if someone does have United and you live on campus, please let me know. I can check your policy individually and let you know if it would work.
I'm talking about the difference between the Advantage plan and original Medicare with the supplement. So there was, when I received the letter, there was a caveat there. You accept Medicare with the supplement, and only, then it was in bold. And can you explain what that only meant? Because you spoke about in-network and out-of-network.
I mean, Jackie, are you talking about something you received from McLean?
Yes.
Yeah, this is communication that would have come from us on what we accept and don't accept. And Michaela's looking at me, but
So,
go ahead.
so your question is, the traditional Medicare versus the United Healthcare plan?
Versus the United Medicare Advantage.
So when it comes to the health center, the big difference there is if you do have United Healthcare, the copays in the nursing home, and you do run the risk of you having a specific United Healthcare plan that we don't contract with. So heaven forbid you were to go to the hospital and need rehab, if you have a plan that has no out-of-network benefits, we're unable to bill your insurance and you may have to go elsewhere for care. With traditional Medicare, obviously we do take that, and as long as you have a 3-night stay in the hospital, there's absolutely no issue.
What I would add to that, just for like from the member standpoint, is, you know, the out-of-network benefits can be considerably more expensive. Like, if you're, yes, there's a lot of PPOs out there. PPO just means you can go in or out of network. My recommendation would be, if you're a resident here and you're using medical services here, I think it's more ideal that you're either in network with your plan here or with original Medicare. It can be considerably more in that situation that was being described. So, and they take some great plans here. So there's no reason, in my opinion, back to checking the doctor and facility thing, there's no reason to put yourself in an out-of-network situation if you don't have to.
So if you have the original Medicare with the supplement, then this situation will not apply?
Yes, if you have the traditional Medicare with the supplement, it's a non-issue,
Okay.
as long as you have that 3-night stay in the hospital.
Yeah, that keeps getting mentioned, and I'll highlight that. So, you know, they were waiving that thing for a while during COVID.
Yeah.
They're back to a hard line with original or traditional Medicare that you have to be 3 days inpatient, not observation, not you happen to sleep at the hospital for 3 days, actually admitted 3 days to the hospital for original or traditional Medicare to pay for skilled nursing. Or, as you said, you're on your own. Medicare Advantage does not have that guideline, but again, they're gonna have to authorize it and approve it, which is a different conversation, but they don't have the 3-day minimum inpatient to go to skilled nursing on Medicare Advantage.
I have a question. How do you get them to say that you're inpatient when a lot of times they just say observation?
So that really comes down to advocating for yours. So how do you basically get them to admit you inpatient versus keeping you in observation? Really, it does if you speak to the physician that's treating you at the time and really advocate or have someone advocate for you. That's really all that I can recommend. A lot of times their line in the sand is, oh, well, you don't require that inpatient care. We're just monitoring you. So I've had people say, well, should I just fake something to get them to admit me inpatient? Well, I don't recommend that. All I can recommend is, advocating for yourself and saying, a lot of times I just say, this is my insurance, and if I'm going to need rehab, they know that you need to be admitted inpatient. So even, I recommend bringing that up as well.
Yeah, so when you're in the ER for 2 days in the hallway and no one's really helping you, don't be stoic.
No, make yourself known.
Yeah.
Obviously, sometimes the more hell you raise, the better the outcome is, truly. And especially in that situation, I can't say advocate for yourself or for your loved one enough, because those costs that come with paying out of pocket for rehab it's anywhere you go, it's astronomical. It's absolutely astronomical. It's very high.
Any other questions?
I was just going to share one quick story. My husband last year, when we were choosing the different plans, he chose to go with the traditional Medicare and a supplement. I thought he was going to go the other way. But I called, on John's recommendation, I called the doctor's office, and we were choosing between a couple. And one of them, when I asked the front desk, I said, oh, it's traditional Medicare. We don't accept that. Now, John had advised me, if the doctor accepts Medicare and you have a traditional Medicare plan, they must. But I didn't want to get into a battle with the receptionist or the girl at the desk. And so I went with, it's crazy, but I went with a different plan that cost a little more money because my husband doesn't like to get in a battle with the person at the desk either. And he liked the ease of just, going up. But that was something that I learned that I thought, if you have traditional Medicare and they accept Medicare, they must, take your insurance. It doesn't matter if it's United Healthcare, if it's Humana, if it's Aetna, anything, they have to take it.
Can I piggyback on that? The same thing happened to me. And a lot of these doctor's offices don't accept Advantage plans. And the staff, relatively new, they really don't understand sometimes the difference between traditional Medicare with the supplement and the Advantage plan. I finally had to go and said, I have 2 cards, Medicare and supplement. Oh, because the Medicare Advantage plan is only 1 card. And so they are confused, and I had to educate these people.
I know, and so
as to
I found
the
that
difference
too.
between the two.
That happened a lot in recent years, probably specifically with Humana, because quite honestly, Humana's Medicare Advantage plan network in Connecticut is not that great. I'm probably being kind. So a supplement has no network. They're just a secondary gap coverage. And a lot of receptionists at doctors 2 years ago were seeing this Humana card, and because they weren't educated, you're right, saying, oh, we don't take that. And people had to really get in these battles. You weren't the only one. But I think Humana's done a good job educating the facilities and the doctors that this is a supplement. It's, it doesn't matter that you don't take our Advantage plan. This is a supplement. And I think we're beyond that. I really do. But yeah, you're right. There was 2 years ago, there was a lot of issues with, the billing or the reception at the doctor's office just not knowing, or because it's something new. So I think we're beyond it. I don't think that's happened in a while, right? Yeah.
I would just say, would you be better off calling the billing office of your doctors than dealing with the front desk?
Yeah, I agree.
Would that-
Sometimes you're probably just better off at the doctor's office saying, okay, just see me, and we'll deal with it later. The billing office is going to probably figure it out. I mean, it does say really big in bold letters on the Humana card, supplement plan G. But yeah, I agree, Kate. Yeah, the billing office is the person that I would talk to if you're having that issue with a supplement.
I don't know of too many surgeries where you're in the hospital for 3 days. They're pushing you out. My husband was overnight for heart surgery and stuff like that. Do I understand you correctly that because he was discharged in 36 hours or whatever, that would not be covered and we are liable then?
No, let me really clarify that. So let me repeat that question because this is an important one. The question was around the 3-day inpatient hospital stay for, and here's the important part, skilled nursing to be approved. That surgery is absolutely covered. You do not owe anything more, other than what your insurance provides. But the difference is, and this would be worked out through the discharge planner or discharge nurse, if you met that 3-day inpatient minimum, if you were able to go to skilled nursing. And again, if you don't meet that 3-day minimum inpatient standard, traditional Medicare is not approving skilled nursing. You're gonna have to go home and have a physical therapist come to your house.
But Medicare Advantage does not have?
It's case by case. I'm not gonna say carte blanche, you can just do that. They do not have that guideline.
Michaela, do you want to address
Yeah,
that too?
yeah.
Michaela deals with this all
Yeah.
the time too.
So if it is a surgery and it's not 3 nights, with Medicare Advantage, they do have to ask for prior authorization for that service. However, that 3 nights does not come into play. So as long as they ask your insurance company and they approve it, that skilled nursing care would be covered.
Oh,
And
So, Michaela, to repeat the insurances we don't take in post-acute. Is that common in post-acute? So I'm just thinking, someone's in a hospital, they need rehab, we don't take it. I mean, is that a common in other post-acutes? What do people do?
so the question was, what do people do when they need rehab and they maybe have an insurance that we don't take or other facilities don't take?
Yeah, so is it common for facilities to all not take the same ones because it's a payer source is there?
So for example, John used Humana as an example. I don't know of many skilled nursing facilities in this area that take Humana, to be honest. So a lot of times those case managers know that's a difficult placement. However, they do know which few facilities do take it. So you may have to go out of Hartford County, and you may end up at a facility you don't want to go to because it is a network with your insurance. So it is, I wouldn't say it's common, the big insurances like Connecticut, but Aetna, Cigna, Blue Cross, most big rehab facilities do take that. And obviously traditional Medicare, I don't know of a skilled nursing facility that doesn't take traditional Medicare for rehab care. So you are limited though to the facilities that do take your insurance, or you're going to a facility that takes your insurance, but you're out of network, and there are significant copays, sometimes, you know, up to $250, $300 each day that you're there.
David?
Maybe this is a question for a billing department, but the bills that the provider sends are often confusing. Typically, they'll show the cost of the service, less the deductible, less what insurance paid, and then there's this mysterious line, adjustment, and then the net is what you are responsible for. Who covers that adjustment? Is that a write-off on part of the provider?
So the question was around specifically the explanation of benefits. I had it mind preset. So there's a monthly statement you're going to get for any kind of insurance called an explanation of benefits. The first thing I'll tell you about an explanation of benefits is, if you notice, in big bold lettering at the top of it, it says, "This is not a bill." So very often, because people get very confused by these things, I don't know the value in paying attention to them, quite honestly, other than just to ensure that your services were approved. The dollars on there, you're right, you see these massive numbers on the left side of the page as far as the cost. Then you see the adjustment. So basically what that adjustment is if it's traditional Medicare, that's what Medicare is going to agree to pay for those procedures. If it's a Medicare Advantage plan, that's based on the contract that particular Medicare Advantage plan had with the doctor or the facility, how much they agreed to pay. And then, of course, on the far right side, to see you pay, I almost say don't even pay attention to the you pay. What you need to pay attention to, quite honestly, is bills from doctors and hospitals. Those are real, okay? Explanation of benefits are kind of fantasy, and they're interesting, that's for sure. Do I think they're valuable for people to review, other than making sure your procedure was approved? I don't know if there's a lot of value of it. It's kind of behind the scenes, back room kind of stuff. It's interesting though. I don't know if you had anything to add to that. Or, okay.
David?
Kayla, so if we don't live here now, we come to live here, sounds like we gotta talk to you.
Absolutely. I'll give you my card. You're more than welcome to set up a meeting with me, and anybody who lives on campus that has any questions or is thinking about moving to campus, I'd be more than happy to meet with you, go over what we cover, things like that.
And this is a case where if we don't have the right plan, would count as a special enrollment.
Well, we're in the annual enrollment period right now, but that would be a special enrollment period. Moving into a facility would constitute the ability to change insurances. Yes, it would. That's a special.
Anybody else? All right, good. All right, well, thank you to our two panelists.